This conference will now be recorded.
Okay. So what is active immunization? What happens is like that this is like natural infection. So we give antigen from outside. So patient's body is able to produce antibodies against that particular antigen. In this, like this principle is used mainly by live vaccines. All the vaccines like live killed vaccines, everything, but the live vaccines, what is importance in that is that where the process that happens is like that maintains the antigenicity and it removes pathogenicity, and usually efficacy of live vaccines are very good. What happens in passive immunization, like we doesn't give any antigen or anything, just directly we give antibodies like tetanus immunoglobulin, rabies immunoglobulin, hepatitis B immunoglobulin, varicella zoster immunoglobulin. Once the patient is exposed to these viral things or antigens, directly we'll neutralize that particular antigen at that point of time by giving ample of antibodies. This doesn't provide any long-term immunity or anything, just it will neutralize that particular period with those antibodies. It is like just at that point of time, it doesn't give any long-term memory or anything. So briefly, that is regarding active and passive immunization. So coming to here contents of this PowerPoint includes definitions, national immunization schedule. You people must know universal or national immunization schedule, and IAP schedule. It is up to you people. It is a bit difficult thing, but everyone must know universal immunization schedule. IAP schedule, just you have to know, but no one is going to ask you in examinations. Why IAP schedule is also important because the other vaccines which are not given in your universal immunization schedule are included. It is like a bit of extinction. And some brief notes on vaccines and special circumstances. Today's class will be covering till brief note on vaccines. In the next class, we'll be going with the special circumstances like immunocompromised and all those things. So basically, what is a vaccine? It is composed of one or more antigens of a pathogenic agent which, when administered to a previously unexposed individual, will elicit an immune response but not a disease. That's why here what happens is the antigen maintains its antigenicity but removes its pathogenicity. That's why the vaccine will not cause any disease. Vaccination. What do you mean by vaccination? It is a process of administration of vaccine. It may elicit either a humoral or cellular response or both. They may ask, define vaccine, or what is the definition of vaccination? So coming to live vaccines, I already told you the efficacy of live vaccines are very good. The importance of this, and it differs from killed vaccines, like it have a multifocal lymph node activation, like it's like a normal infectious phenomena. When any antigen enters into the body, it activates multiple lymph nodes. So obviously, you know, multiple lymph node will be having all germinal centers and activation of T lymphocytes, and the immune memory will be very good, and production of antibodies are like lots. So multifocal lymph node activation is specific for live vaccines, not for killed vaccines. So potency of the organisms has been attenuated, so it maintains their antigenicity. Usually you have to remember, for any live vaccines we require minimum of 2 doses. And one more important thing, for any live vaccine, cold chain to be maintained, like for BCG vaccine, oral polio vaccine, typhoid vaccines. These are all live vaccines. Like typhi oral is a live vaccine, but we doesn't have typhi oral yet in India, in our state especially. So those are all heat and light sensitive vaccines. So they have to be protected from both heat and light. So coming to live bacterial vaccines, they are, you know, BCG and typhoid. BCG we give in our universal immunization schedule. Coming to live viral vaccines, they are measles, mumps, rubella, oral poliovirus, Japanese encephalitis, chickenpox like varicella, rotavirus vaccine, and yellow fever. So I already told you live vaccines are more sensitive for heat and light. So they should be having properly maintained cold chain for those vaccines not to get inactivated. The only one vaccine which is even like freeze sensitive. So these vaccines all can be freezed, but the only one vaccine that should not be freezed, even though it is a live vaccine, that is your rotavirus vaccine. That one you must remember, because rest of the vaccines, if it gets freezed also it's okay, but not the rotavirus vaccine. And one more important thing in live vaccine that you should know is like, see, this is a question for you. Are you people like, can you give 2 live vaccines at a time, or at least a gap? You must be expecting. Anyone can tell. I'm not picking up any roll number. It's up to you. Anyone can tell, or else I'll ask. Can we give 2 live viral vaccines at a time, or else do you want to maintain any gap? Or else, if you want to maintain any gap between the 2 vaccines, what is the gap you expect to maintain? Roll number 58. Okay, someone is
On
answering.
two
Tell me.
different, I
Gap
mean,
should be maintained, ma'am.
Yeah, how much
Minimum
gap should
1
be
day.
maintained?
Minimum 1 day.
So, ante ela cheptavu nanna, today you'll give oral polio. Okay, OPV is not like, okay, today you are going to give varicella and tomorrow you are going to give measles.
4 weeks gap, ma'am.
Yeah, very good. At least, see, you can give at a
antibody.
time. What? Tell me. You can give at a time, like more than 1 live vaccine can be given simultaneously. There is no problem when
On
given
two
simultaneously.
different limbs they are given, ma'am. On deltoid of left or right.
I didn't understand, ma.
On 2 different limbs they are given, ma'am. I mean upper limb.
Yeah, on 2 different limbs, even same limb like thigh, it is having wide surface area, right? It can be given. The point is here, live vaccines can be given simultaneously on the same day. There is no problem. But not like, if at all it is missed on the same day, it should be given at a gap of 4 weeks. Someone told me correctly, because at least at that point of time, if anyone missed one vaccine, cannot give in the next week. That if at all it is also a live viral vaccine, at least a gap of 4 weeks you should maintain, because of the immunological interference between 2 vaccines. So if at all if you want to go, you can give on the same day, or else you wait for a 4 weeks at least. You have to know this, because in your examinations they are asking in your viva. So because of immunological interference, we have to maintain a gap of at least 4 weeks for a 2 live vaccines. You can give live vaccine and kill vaccine at any point of time, but usually we prefer for any vaccine to maintain a gap of 4 weeks. That is the thing. So next is your killed vaccines. The killed vaccines do not cause infection but elicit protective immune response. Killed vaccine usually requires multiple and booster doses. So can anyone tell what are the types of killed vaccines? See, rest of all the vaccines like DPT is a killed vaccine, hepatitis A is a killed vaccine, IPV is a killed vaccine, influenza. Do you expect, or even pneumococcal, meningococcal, all these vaccines are killed vaccines, right? So first of all, you have to know what are the types of vaccines. One is live, one is killed. Any other components? Others are subunit vaccines, and another one more entity is your toxoids. So killed vaccines examples: whole cell pertussis vaccine, IPV, hepatitis A. So these are all the examples you have to remember. Coming to your toxoids, these are nothing but modified toxins, attenuated toxins. We'll do attenuation of all these. Examples are tetanus toxoid and diphtheria toxoid. Another important things are subunit vaccines. Here we cannot use entire antigen as a vaccine. We will take a part of antigen as a vaccine. Those could be either a protein or a polysaccharide. So in subunit vaccines, protein if we take, That is, example is hepatitis B and acellular pertussis vaccine, effective vaccine, and it is a safer vaccine. Coming to your polysaccharide vaccine, here what happen is like we generally have vaccines against capsulated organisms. It is usually not a good antigen, cannot be used in the age of less than 2 years. So we have to convert polysaccharide vaccine into a like a conjugated vaccine by conjugating it with a protein. So we all have vaccines like pneumococcal conjugate vaccine, meningococcal conjugate vaccine, all these things. So conjugate vaccine is nothing but combination of a polysaccharide and a protein. So protein is every time a good antigen. So whenever we are taking antigen or a part to use a vaccine, protein is better when compared to a polysaccharide vaccine. So that's why we are now using conjugated vaccines. That's why. And one more thing is polysaccharide vaccine we cannot give or we cannot use in age of less than 2 years. So these are all protein conjugated polysaccharide vaccines. I already told you pneumococcal conjugate, meningococcal conjugate vaccine. Another one more I didn't mention here, that is typhoid conjugate vaccine. And usually we give the combination vaccines. This doesn't affect any efficacy of that particular vaccine. It is beneficial because of avoiding all the multiple injections to the baby. So at a one stage you can give all these vaccines. That is called as pentavalent vaccine. They'll ask you what are the components of pentavalent. DPT, 3 components: diphtheria, pertussis, tetanus. 4th component is Haemophilus influenza, and 5th component is hepatitis B. See, there is no polio component in your pentavalent. Pentavalent is nothing but DPT, hepatitis B, and Haemophilus influenza. Please, you have to know the combination, what it includes in your pentavalent vaccine. So some points like in your vaccines, before going to your immunization schedule, you must know what is an adjuvant, what is a stabilizer. See, you know, magnesium chloride is a stabilizer that will be there in oral polio vaccine. Magnesium sulfate is a stabilizer that is present in measles vaccine. See, in stabilizers helps during storage process. So effectiveness during storage is improved by stabilizers. What do you mean by adjuvant? Adjuvant is like to increase the efficacy of the vaccine, we use adjuvants. There is lot of difference between an adjuvant and stabilizer. Please do not club. If you don't know what is an adjuvant, what is a stabilizer, don't utter a word or don't club. Magnesium chloride is a like adjuvant. This is different entity. One is for your storage purpose, one is for your efficacy purpose of the particular vaccine. Okay. Even stabilizers are also used for live vaccines like lactose sorbitol and sorbitol gelatin, that is out of your entity. Just remember, there are other components even are included in a vaccine. Those are adjuvants. Adjuvants usually we use are aluminum salts in a killed vaccines, that is to increase the efficacy of the vaccine. Stabilizers are like effectiveness to maintain during storage period, that is the usage of a stabilizer. And another entity is a preservatives. Why we use preservatives is like to prevent bacterial and fungal growth. The commonly used preservatives are thiomersal and phenol. But what is the recent contradictory point to the thiomersal? It is associated with autism, but not according to like IAP schedule or AAP schedule. This is like a myth. It is a completely controversial entity. So we have to know the 3 terminologies: what are adjuvants, what are stabilizers, what are preservatives. Adjuvants to increase the efficacy, stabilizers to maintain the storage period and also to effectiveness, and preservative to prevent growth or infection in that particular vials. So usually preservatives we use in a multi-dose vials. Why in multi-dose? Because once it opens, it will take time for 10 people to get vaccinated. So in order to prevent all the contamination, we use preservatives. Commonly used preservatives are thiomersal and phenol. In some vaccines like MMR and IPV, even we use antibiotic, that is neomycin, as a preservative. These are all the things you should know. So next is like before jumping into the schedule, you have to know what are the different sites that we administer vaccine. Someone can answer. What are the routes we prefer for a vaccination and why? చెప్పండి. Are you there? Am I boring? Am I audible?
Yes, ma'am.
Yes, ma'am.
So what are the different modes of administration of vaccine? Just IM, subcutaneous, intradermal, all these we give, and why? You have to know why, right? Why we are giving particular vaccines as intradermal, why we are giving particular vaccines as intramuscular, why we are giving some vaccines subcutaneous, that one should know. Intradermal is a potent thing, like more of dendritic cells will be there, more of vaccine uptake will be there, but the vaccines that we give intradermal are, anyone can give some guesses? Any guess?
BCG.
Intradermal, BCG, ఇంకా జస్ట్ ఊరికే అసలు మీ ఫేస్లు కూడా తెలియట్లేదు కదా, నన్ను ఊరికే ర్యాండమ్ గా చెప్పండి, నేను చెప్తాను. ఆర్ ఎల్స్ యూ కెనాట్ మెమరైజ్ ఎవ్రీ వ్యాక్సిన్ పార్ట్. దట్స్ వై, బికాస్ when we were doing our UG period, the same thing used to happen. We used to get confused for intradermal, subcutaneous, intramuscular. We used to club everything. That's why, if at all it is an interactive session, you people, like, you'll memorize everything at this point, and later on you can discuss among yourselves. That is the ideology, not like harassing you people. Just just to give a fluke or anything, ఒక రాడేగా వెయ్యండి, ఏముంది. So intradermal one is BCG, simple one. Rabies,
IPV.
rabies intradermal. Yeah, IPV, it is intradermal. See, the why we are giving IPV intradermal is your question, because in only our immunization schedule we are giving fractionated IPV. The rest all things, like in hexavalent vaccine, all the things we give vaccines, killed vaccines, usually IM only. And because of this fractional IPV, what is the advantage is, like, it is the 1/5 dose of IPV. So the dose is 0.1 ml, and it is equally effective as be administered through the dose of 0.5 ml in IM. So for that immunization purpose also, we are giving the fractionated IPV. So you have to remember only 3 things. The intradermal vaccines are BCG, fractionated IPV, and ARV, rabies vaccine. Even rabies can also be given both intradermal and intramuscular. The only vaccine that can be given only through intradermal is your BCG. That's all. That is more than enough. Out of all these, IPV and ARV, those are all killed vaccines. BCG is a live vaccine, and it acts through cell-mediated immunity. Okay. Next is your subcutaneous. See, there is no particular thing, like one thing, like your live vaccines, you can give either way, either subcutaneous or intramuscular. Killed vaccines, the preferable route is deep intramuscular. Why deep intramuscular is, it is well vascularized, and if at all, if we give the killed vaccines to subcutaneous route, not very well vascularized, so efficacy will be low, and the immunological response will be low, and the vaccine uptake also will be low. So it requires multiple boosters. That's why when we are giving killed vaccines, you see any killed vaccine, we prefer route of intramuscular. So if you don't know anything regarding the vaccine, just you know only whether it is live or viral, then you can tell. If it is killed vaccine, you can tell it is intramuscular. The only exception for a killed vaccine that is given subcutaneous is meningococcal vaccine. We don't put meningococcal vaccine in your viva because it is not there in immunization schedule, and we are not giving over here in Andhra. But the only thing that you should know, all killed vaccines that can be given deep intramuscular because of the well vascularized areas. The only exception is meningococcal vaccine. All live vaccines can be given both subcutaneously and intramuscularly. We prefer subcutaneous, but why? Because it is less painful. See, when both modes are effective, and if it one route is comparatively less painful, what will we opt? We obviously opt subcutaneously. So there is nothing like, you may ask, why MMR, madam, we are giving subcutaneous? Live vaccine, it is equally efficacious in both IM and subcutaneous. Either route can be given. So if it, because it is less painful, we choose subcutaneous route. So this is the basic thing. So once you have an idea on this, like killed vaccines intramuscular, live vaccines both the entity, subcutaneous is less painful, more than enough when you are reading up your individual vaccines. So what are the other routes? Till now we've discussed intradermal route is there, intramuscular is there, and subcutaneous is there. Other routes are like nasal route. one nasal route vaccine, that is flu vaccine, just your theoretical purpose. And what are the oral route vaccines? There are 3 vaccines that can be given oral. One is oral polio, one is your rotaviral vaccine, another one is typhi oral. Typhi oral usually we won't give here, and it is given for age of more than 5 years, because typhi oral vaccine comes in a capsules. So less than 5 years cannot put the tablet individually, and it is also an enteric coated formulation. Here, see, it is not available in India. So oral vaccines, you have to be very confident, oral polio and rotavirus. If anyone asks, one more vaccine is this, that is typhi oral. That's all. So you expect some reactions for every vaccine, some rare, not like routine. Those will be covered in your individual vaccination thing. And so you have to be very clear. Till now I discussed what is a vaccine. What do you mean by vaccination? What are the types of vaccines? They are live vaccines and killed vaccines. And also killed, there are other entities like protein subunit vaccines and toxoids. In subunit vaccines, it can be either proteins or polysaccharide vaccines. Till that point, you have to be very clear. And what are the different routes of administration of vaccines for oral vaccines and for live vaccines? Sorry, for live vaccines and for killed vaccines. So next we are going into schedule. See, I'll try to make easy so that you can memorize, but I cannot do anything, because it's your job to by heart it or do whatever thing you want, because there is nothing to tell in this schedule part especially. So at birth, what are the vaccines that can be given at birth? See, all these vaccines you have to know. One vaccine, BCG, oral polio vaccine, and hepatitis B. See, hepatitis B in all the immunization schedules, it is very important vaccine, because hepatitis B, if the infection at the early age, the chance of like a carrier stage or hepatocellular carcinomas will be very high. That's why even not only in our universal immunization schedule, in every schedule, you cannot expect BCG or oral polio in other states or other country vaccination, but we expect hepatitis B. Still, it is rampant all over world. So these are the vaccination, because we can, if we administer vaccine properly at the birth only, then we can prevent the long-term consequences if any child gets hepatitis B. So at birth, what are the things that we give? BCG, oral polio vaccine 0 dose, and hepatitis B birth dose. So there are 3 vaccines. So 6, 10 and 14 weeks. OPV 1, OPV 2, OPV 3, pentavalent 1, pentavalent 2 and pentavalent 3 vaccines. Rotavirus 1, 2, 3. So these are the 3 vaccines that can be given 6, 10, 14 weeks. So as simple as such. So there are 3 vaccines at 3 weeks of schedule, 6, 10, 14 weeks. They are OPV, Pentavac and Rotavirus. 6 and 14 weeks we give fractionated IPV and pneumococcal conjugate vaccine. See, pneumococcal conjugate vaccines, these are not there in India. It is only limited to particular states. In the next slide, you'll be having in where are we giving those states. Himachal Pradesh, Bihar, UP and Madhya Pradesh and Rajasthan. These are the vaccines that we are giving PCV. It is not yet included. All over the thing, all over in Andhra Pradesh, it is not yet there. What are the states that are giving pneumococcal vaccines? You should know. Some may ask, are we giving here? Because pneumococcal vaccine is expensive, ma. So other vaccines like fractionated IPV, 1 and 2 doses at 6 and 14 weeks. Next, at 9 to 12 months, we are giving measles 1 or MR, Japanese encephalitis 1 and pneumococcal booster. 16 to 24 months, second dose of MR, Japanese encephalitis second dose, DPT booster and OPV booster. 5 to 6 years, we give booster dose of DPT. Previously, we used to give here OPV booster of another dose. Now it is not there. Only DPT booster 2 we are giving. So 16, 14, OPV 1, 2, 3, Pentavac 1, 2, 3, Rotavirus 1, 2, 3. Along here 9 to 12, we give Japanese encephalitis 1 and 2, 16, 24, 1 and 2. MR 1 and 2 at 9 to 12 months and 16 to 24 months. Here 9 to 12 months we give booster of pneumococcal, and 16 to 24 months we give booster of DPT. 15 to 5 to 6 years, there is only one booster in your universal immunization schedule, that is your DPT booster 2. 10 and 16 years we give TT. Pregnant mother we give tetanus 1 or 2 or tetanus booster if it is adequately taken. See here all these stars indicated. 1 star in endemic districts only. 2 stars, that is here booster we gave 2 stars. Why? 1 dose if previously vaccinated within 3 years. So not in every pregnancy there is must and should to give 2 vaccines. If the mother is already pregnant in before 3 years and properly vaccinated, you can give only 1 dose of booster. That is more than enough. Rotavirus vaccine and PCV in selected states. MR vaccine introduced in selected states and planned to expand to other states. That do you mean by this hash mark? So rotavirus vaccine phased in introduction at present in Andhra Pradesh. So in Andhra we are giving rotavirus vaccine. Pneumococcal vaccine we are not giving in Andhra Pradesh. JE vaccine we are giving in Andhra Pradesh. So what are the vaccines that are not yet implemented in Andhra Pradesh is pneumococcal vaccine. Rotavirus, Japanese encephalitis vaccine and MR vaccine. I think you better note down all these states. It can get anywhere. In your textbooks also it is there. We have to know pneumococcal we are not giving. The states where pneumococcal vaccine is given are Himachal Pradesh, Bihar, UP, MP and Rajasthan. That's all. At last we'll come to this in IAP schedule. You people, all the whatever strength is there in the class, entire batch should know universal immunization schedule. There is no point in losing or telling mistakes in universal immunization schedule. It is optional. If you want to memorize everything, you can, or else there is no issue. So coming to your individual vaccines, the first thing is, and one more thing, we cannot cover in your practical class, that is Mission Indradhanush. If time permits, in the next immunization class, we will discuss even on Mission Indradhanush also. So the next vaccine is BCG. So first vaccine in your schedule or what given to the baby is BCG. At birth we'll give. Usually, if at all at birth, if it is missed, it can be given till 1 year of age in universal immunization schedule, and in up to 5 years in IAP schedule. Okay, so routine when will be given at birth or at first contact. One thing you have to remember, see, before administering anything, we'll just clean it with spirit and all, but for a BCG vaccine, you should never clean the area where we give the vaccine with a spirit. You have to clean it with your normal saline that they will ask. Why? Because as spirit kills live attenuated bacilli given superficially. So there is no point in killing the bacilli whatever we are giving. That's why we usually clean with your normal saline. The mode of administration already we discussed, it is intradermal. So why we are giving BCG? Because it protects 50 to 80% prevention of miliary and meningeal forms of tuberculosis. Protective efficacy for tuberculosis, that is pulmonary tuberculosis, is low, that it is 50% only. Usually it is mediated through cell-mediated immunity, this vaccine. So maternal antibodies enhances T-cell response. There is no problem in giving this particular vaccine, because rest of the vaccines where acts through humoral immunity, maternal antibodies will neutralize the particular vaccines. That's why we don't preferably give remaining vaccines and we are giving multiple doses of vaccines. So next is after we give BCG vaccine, what will happen? At what time papule will develop? 2 to 3 weeks, followed by scar development at 6 to 12 weeks, and that papule enlarges to 4 to 88 millimeter by end of 5 to 6 weeks. That is the thing they will ask, when do we expect any scar after BCG vaccination is your question. And rest of the thing you have to read what is the strain in your BCG vaccine and all these things. Where will we give BCG vaccine? That is your question, and why. We give BCG vaccine at left upper arm. Next, for any vaccine, one more thing you have to know, what is the first dose and what is the extended dose, till at what age we can give that particular vaccine also one must know. So next is your OPV. So till now we discussed an immunization schedule. At birth we'll give to initiate early immunization against polio, and also like no maternal IgA is present in the gut. Nowadays we are preferring IPV, and we are already introduced fractionated IPV in our schedule, because IPV, vaccine associated paralytic polio, we can prevent through IPV. IPV is equally efficacious as OPV, and even the best thing is seroconversion rates of IPV is 90 to 100%. I already told you IPV can be combined with a pentavalent vaccine, then we call it as hexavalent vaccine. In that hexavalent vaccine, we usually give IPV through your intramuscular route. But in our schedule, IPV is given through fractionated doses of 0.1 ml, because it will come for 5 people and 5 doses, and immunogenicity will be good. So we give fractionated IPV in our universal immunization schedule. Usually IPV, we discussed catch-up doses, if at all missed, 2 doses 2 months apart, followed by booster at 6 months. This is your IAP schedule. I'm not insisting on IAP schedule, just only remember universal immunization schedule, that at 6 and 14 weeks. So this is your universal immunization schedule. Once again, I am repeating: at birth, at 6 weeks, 10 and 14 weeks, at 6 to 24 months. Previously, there used to be have a OPV booster of another dose at 5 to 6 years, but that it's not there in 2018 universal immunization schedule. So catch up IPV. Up to 5 years you can give 2 doses. You have to give. What do you mean by catch up? Means if at all anyone missed, or your first contact is at around at the age of 1 month or so, you have to give your IPV. At that time you have to give 2 doses 2 months apart. Like 1 dose you'll give, and a second dose will be after 2 months, followed by a booster you have to give after 6 months. That is up to 5 years. Catch up OPV you can give up to 5 years of age. Next is your whole cellular pertussis or acellular pertussis. Both are equally efficacious. Actually, whole cellular pertussis is better efficacious, but because of your side effects, we prefer DTaP, and it is contraindicated. It is usually contraindicated in more than 7 years of age. We already dealt with your immunization schedule, the route of the dosage of 16 and 14 weeks, boosters at 15 to 18 months and 5 years. In universal immunization schedule, we give it as a pentavalent vaccine. Usually, the side effects are due to pertussis component. What are the absolute contraindications of this pertussis, like DTP, that is whole cellular pertussis vaccine, is history of anaphylaxis. Where history of anaphylaxis, like previous anaphylactic reactions are there for a particular vaccine, then it is an absolute contraindication. Development of encephalopathy within 7 days following previous whole cell pertussis vaccine, that is also an absolute contraindications. Rest like fever, persistent inconsolable cry of more than 3 hours, hypotonic hyperresponsive episodes, these are not absolute contraindications, these are all relative contraindications. So if anyone asks what are the absolute contraindications, we have to tell one is previous anaphylaxis. There is no point in giving once the child had anaphylaxis for that particular vaccine, or development of encephalopathy within 7 days following previous whole cellular pertussis vaccine. So these are the two things. So catch it, if less than 1 year, we can give 3 doses at 4 weeks interval, like 16 and 14 weeks we gave, like with a difference of 4 weeks. The same thing we can follow for 1 year, less than 1 year. If 1 to 7 years, 3 doses can be given at 0, 1 and 6 months. If more than 7 years, we cannot dare to administer this DTP, then you have to give TDAM, where we get tetanus, diphtheria and acellular pertussis with lower amounts of toxins present, and also TD at 0, 1 and 6 months of age. So this is the thing with whole cellular pertussis and TDAP. Next, your measles vaccine. Just I'm giving all these vaccine schedules, mode of administration, and when to give the catch up. You have to memorize your strains, right? Like measles, Edmundston, Zagreb strain, all these strains will be there. You have to mug it up because that is not, that is the most of theoretical purpose. You have to read. Examiners may ask, but routinely they'll ask these questions. What is the age? What are the side effects? What is the schedule? And if at all the child is mixed with that particular vaccine, till what point you can administer that vaccine, they'll ask. See, any vaccine can be combined with the BCG, but not MMR vaccine. So MMR vaccine cannot be given with that. Usually nowadays we give vaccine, measles not allowed. We are giving measles and rubella MR vaccine now. Best at the age of 12 months because for balanced and early protection, 9 completed months we are giving because maternal antibodies will completely be weaning at that period of time. For that point, we are giving at around 9 to 12 months. In our universal immunization schedule, we give at 9 to 12 months and measles second dose at 16 to 24 months. If for suppose any measles outbreaks are there, we have to give an early dose or at around 6 months, but the dose is not counted. We have to give the rest of the other 2 doses as usual. Catch-up MR vaccine, it can be given up to 15 years. So you have to know what is the catch-up vaccine day for everything. Till now we discussed BCG, oral polio, IPV, pertussis and measles, right? So BCG, lower age like at birth or at first contact, upper age 1 year according to our UIP, 5 years according to IAP, OPV at birth and can be given till 5 years of age, IPV 6 weeks and can be given till 5 years of age, pertussis that is whole cellular pertussis DTP or acellular pertussis DTAP, that lower age limit is 6 weeks, upper age limit is 7 years of age. For measles, usually lower age limit is 9 to 12 months, upper age limit catch-up is up to 15 years. So the next is your Haemophilus influenza vaccine. This is also a part and parcel of your pentavalent vaccine. It is a protein conjugate vaccine, I already told you. It can be given as early as 6 weeks. Why? I already told you polysaccharide vaccines cannot be given in less than 2 years of age. Conjugate vaccines we can give. The vaccination routinely we give in 6, 10, 14 weeks, boosted at 12 to 8 months. Catch-up for Haemophilus influenza is till 5 years of age. So in till 5 years of age, but that is not same for all the ages. For suppose if the child is less than 6 months of age, 3 doses can be taken along with 1 booster, that is 4 doses they will be taken. If the child is 7 to 11 months of age, once the child crossed that 6 months of age, then we can give 2 doses followed by 1 booster. So total of 3 doses we will give. If the child is more than 1 year of age, just we give 1 primary dose and a 1 booster dose. At least a gap of 8 weeks should be maintained. If the child is more than 15 months to 5 years, single dose is sufficient. So you have to know how many doses you give when the child is going on increasing with the age. If at all at the initial stages, like less than 6 months, total of 4 doses we will be giving. For 7 to 11 months, 3 doses, that is 2 primary doses, 1 booster dose. For 12 to 15 months, we give 1 primary dose and 1 booster. For more than 5 years, like not more than 5 years, from 15 months to 5 years, a single dose of hepatitis B is sufficient. So you cannot go on giving the same vaccination schedule for a 6 months baby to a 12 months or to 12 months baby to 15 months. There are individual set of dosages for that particular age group that you have to remember. There is no point in explaining, so you have to memorize. So, and one more thing, why we are giving Haemophilus influenza, hepatitis B, we know name itself indicates prevents against hepatitis B, oral polio or prevention against polio virus, rotavirus, prevention against rotaviral diarrheas and all these things, measles against measles. Then what it does with hip vaccines protects against Anyone can tell what is the role of Haemophilus influenza vaccine giving?
Preventing meningitis.
Okay, still more? Only meningitis? What are the diseases that are caused by Haemophilus influenza? One is meningitis, very good. There are so many things: meningitis, otitis media, sinusitis, even osteomyelitis, some cases of pneumonia, and even bacteremia. These are all the things. To prevent all these things, one who told, I don't know, but you are very apt, because after the introduction of this Haemophilus influenza vaccination, meningitis cases came down very drastically. Next is your rotaviral vaccine. So in your universal immunization schedule, we give rotavirus pentavalent strain, that is RV5, of 3 doses, 16 and 14 weeks. Minimum age is 6 weeks. And one more thing, it is a live vaccine. The only live vaccine that cannot be frozen or freeze is your rotavirus vaccine. One important thing with your rotavirus vaccine is your vaccination time. Maximum dose for first dose is 15 weeks, and maximum age for final dose is 8 months. So you cannot give your rotavirus first dose if the child doesn't take till 15 weeks of age. If the child presented to you at your 16 weeks or 20 weeks or at 5 months, you cannot administer your first dose. So there are cutoffs for even first dose in this particular rotavirus vaccine. This is difference with the rest of the vaccines. See, rest of the vaccines we are not pertaining ourselves when does we have to give our first dose, but this is specific for your rotaviral vaccine. Your first dose cannot be administered if the child is having more than 15 weeks, and the final dose you cannot administer if the child is more than 8 months. So the vaccination schedule should be completed before 8 months at whatever cost. So you cannot go on giving like a routine doubt, right? Only if you remember 8 months, the dose cannot be given more than 8 months. If the child was unvaccinated and the first dose, if you are giving 7 months, that is a blunder. So maximum age for first dose is 15 weeks and maximum age for final dose is 8 months. That is your rotavirus vaccine. And what are the expected complications of rotaviral vaccine is GIT symptoms like diarrhea, vomiting. These are all routine things. And also the most potential complication is if you are intussusception. Okay, RV1 is Rotarix, RV5 is Rotatec. We administer Rotatec, that is 5 drops. Oral polio we give like 2 drops, right? Rotavirus we give 5 drops of rotaviral vaccine. See, Rotarix administration, if at all if we want to give, the thing is the minimum age is 10 weeks. Rotatec, that is RV5, 3 doses, we can start at the age of 6 weeks. Despite of starting the first dose at 10 weeks, the maximum age for the first dose is 15 weeks only. Next is your hepatitis B. It is also included in your pentavalent vaccine. The dose schedule is 16 and 14 weeks. See, ideal minimum interval between a dose, 3 doses we are giving, right? For first and second dose, it should be like 4 weeks, and second dose and third dose, it is like 8 weeks. That is ideal. There are so many schedules. You can remember just one thing, like 16 and 14 weeks. That is easy for you. Ideally, final dose in hepatitis B vaccine series should be administered no earlier than age of 24 weeks and at least 16 weeks after first dose. These are the ideal recommendations, but we give birth dose even. For catch-up vaccination, we prefer 0 and 1/6 months. Like I think all you people had already taken your hepatitis B vaccine. The schedule is 0, 1 and 6. Because of better seroconversion rates, this is the most accepted schedule. See, for suppose if the mother is 1, we give hepatitis B at birth, right? Remaining all rest of the vaccines like hepatitis, like BCG and oral polio, irrespective of whether the child is premature, what is the age, what is the weight of the baby, we doesn't think all those things. We give universal immunization schedule for all the babies. Once the baby gets stabilized, like for preterm babies or babies of low birth weight, if the babies are in ICU, We just wait whether the child is not on any antibiotics and the child is feeding well and gaining weight, then we give the rest of the vaccines. But hepatitis is the only vaccine that we wait till 1 month of age, or at least the child should gain weight of more than 2 kilos. So we have to administer this particular hepatitis B vaccine, we'll wait. But this does not apply for one condition. If the mother is hepatitis B positive, we give irrespective of state, gestational age, irrespective of weight of the baby, we administer hepatitis B vaccine even with the child is low birth weight. If the mother is hepatitis B negative and there are no potential risk factors for hepatitis B and the child is preterm, we'll wait till 1 month of age or till the baby gains weight of more than 2 kilos. For suppose if the mother is hepatitis B positive and you're adequately immunized and you have to know whether the child is protected or not, you have to check at around 9 to 18 months. You have to check both the status of HBs AG and anti-HBs status to be checked, and the protective values are 10 milli international units per liter, because here the antigen we used is HBs AG. That's why we check the antigen and as well as protective antibody levels titers. If only anti-HBs level titers are very fine, that is more than 10 milli international units per liter, there is no point of giving revaccination. The child is effectively protected with our previous vaccination. That is more important thing. Shall I continue the rest of the vaccines in the next class? Because we are having remaining vaccines like some 5 to 6 vaccines along with vaccines in special circumstances. So be prepared for your next class with your properly have to know, every student should know their universal immunization schedule, what are the vaccines and what are the different modes of administration of the vaccine. See, if at all examiner asked you to pick up some vaccine and ask you to tell something on that particular vaccine, you start. What is the vaccine? Whether it is a live vaccine or killed vaccine, or whether it is a subunit vaccine or it is a toxoid, you start from there. And what is the mode of administration, you have to tell the next point. What is the minimum age? What is the maximum age? What is the vaccination schedule in your routine immunization schedule? If at all any strains are there, you have to mention on that particular strain. And also what are the possible adverse effects. These are all the side headings you have to tell whenever examiner asks you to pick up the particular vaccine. So don't confuse the mode of administration of all the vaccines. I already told you, for a killed vaccine, IM is more preferable. For live vaccine, subcutaneous or IM, subcutaneous is less painful. So if you are not confusing in this part, along with your vaccination schedule times, 6, 10, 14 weeks, when will we give MR like 9 months? When is the booster like 16 to 18 months? That is more than enough. Shall I continue with, or shall I end? Shall I continue with one more vaccine? Like, shall I continue with your pneumococcal or shall I stop the class?
Ma'am, next class, ma'am.
Okay. See, I know because this is nothing but you have to by heart it, you have to read it multiple times. So go through your OP guide textbooks if at all it is there with you. Just as basics of immunization, that is what is active immunization, what is passive immunization, and all these things read for today. And the next class will continue the rest of the vaccinations and vaccines in special circumstances. Any doubts are there, you can ask me directly or you can ask me in WhatsApp group either. Any doubts for now?
Ma'am, BCG for scar formation, can you please explain one?
అర్థం కాలేదమ్మా.
బీసీజీలో స్కార్ ఫార్మేషన్ అన్నారు కదా.
మళ్ళీ చెప్పనా?
బీసీజీ వ్యాక్సిన్ లో స్కార్ ఎప్పుడు ఫామ్ అవుతుంది అని?
12 weeks.
Okay.
See, BCG vaccine, after giving vaccine, we expect a papule at around 2 weeks. Small papule, it gradually increases in size of 5 to 6 millimeter, around 5 to 6 weeks. A proper scar will be formed at around 8 to 12 weeks.
Okay, ma'am. Thank you.
If at all any pictures are there with all these vaccinations, I'll put one PowerPoint presentations for you people in 9th semester class, then you can read it out. Okay, thank you.
Okay.
ఏమైనా డౌట్స్ ఉంటే అడగండి, or else we'll leave the meeting.